Welcome to today's webinar. The topic for today is effective management of infections, innovative technology to help you control, track, and prevent the spread of infection. My name is Karl Seagren, and I'll be hosting today's presentation. As a reminder, this webinar is intended to provide general information, but not legal advice. We have a great expert joining us today, and I'm honored to introduce her. Jeanne Gray is a healthcare consultant with over 25 years of experience in the healthcare industry, ranging from inpatient and outpatient management to serving as a CEO and managing multi-state facilities. Currently, Jeanne works with medical practice management professionals and large healthcare systems to implement new and innovative approaches to work cost-effectively, specializing in strategy creation, processes, and policies to execute initiatives to manage risk and coordinate care across systems. Jeanne, I'll turn it over to you.
Thank you, Direct Supply, for hosting this webinar. It's greatly needed in this time. So one of the things that we're going to be covering today, let's go through our objectives. I want to make sure that we all understand how the challenges of COVID have changed our world and created some effective long-term changes within our healthcare system. Also want to look at it and identify the gaps that were exposed during our most recent pandemic. Examine the importance and the flexibility of being proactive and using data analysis to prevent extensive damages going forward. Also, how to explore and set goals to minimize these negative outcomes for the future, and apply our lessons that we learned to create proactive future planning processes. Some of the challenges that we identified during the most recent pandemic over the last 3 years were things that impacted you guys more than anybody in the healthcare world. They were serious financial impacts to the long-term care market, as well as staffing challenges that continue to this day related to how we staff, what we staff, and what that looks like. There were also additional reporting challenges that were identified through this process for a lot of different reasons, and we will take a look a little more in depth at that as we go along. There were patient safety issues that were identified that we've never had to deal with in the past, and those will be important for us to cover some of those specifically. There was also additional survey challenges that are now being met with new SOPs that are being developed, as well as fines that are being imposed upon each of us on a daily basis. And then there was also the risk of staff exposure to some of the disease processes that normally we have not had to manage or deal with in the past. So let's delve into those a little bit more. Next slide, please. When we're talking about the financial impact, we can't do that without saying the cost of care rose dramatically during the pandemic, from everything from the staff that we had to have, to the supply cost, to the cost of what we were having to pay for the labor during that time, as well as the civil monetary penalties that came into play along with that financial impact. It was a really trying time financially for the long-term care market, and I'm certain I don't have to say that to each of you. So we'll look at how we're going to deal with that going forward. Next slide. The staffing impact is one of the ones that has continued to hang around for us. Already staffing in long-term care was at an astronomically high rate, but it's now at a turnover of all-time high. We realized very quickly that there's a huge shortage of lack of qualified workers, and that those workers that we're hiring now need to have more qualifications, more education, and more background in areas that previously they did not need to have as much expertise in. There's also the increased workload, the greater competition in the market for those same healthcare workers. Used to, the CNAs were no longer needed at the hospital. They weren't used anywhere else. And so we kind of had, for years, had the run of the market on the CNA population. That's no longer the case. We're now competing with home care markets, home health markets, hospice markets, as well as hospital and acute care. And part of that in the staffing impact has to do with the increase in the workload. If a CNA has the option of taking care of 12 patients or going to work in a home care setting, sometimes they will choose that one-on-one patient caseload as opposed to the requirements that we are needing in the long-term care for that additional staff. So knowing that and going forward, we've got to make some preemptive plans for what that's going to look like going forward. Next slide. One of the other things that greatly increased for long-term care during this pandemic was the need for reporting. We're doing reporting now at an alarming rate that has never been tracked and trend in the long-term care market before. NSHN reporting on a weekly basis, not only for your staff, but also for your patients. We previously in the long-term care market didn't really have to keep track very much of what was going on infection wise with our staff. And now that's having to be reported on a regular basis, not just for COVID now, but also for other areas such as flu, pneumonia, vaccine rates. All of those things are now being required that weren't previously. Additional CDC reporting and mapping those things over. Looking at OSHA reporting where it relates to workman's compensation over the past 3 years in the long-term care market has been higher than it has ever been related to our staff contracting some of the diseases that have taken over in some of our areas. All of that has only impacted the survey process. It has, we're having to do greater surveys. We're having all the infection control surveys now as well. So all of the reporting for that, we've always had 2567s, but this has been at an alarming rate over the last several years. All of this needed to flow into a process for our QAPI and for the health department in order for us to be able to report on a global basis. Not only did it identify that we lack some reporting capabilities in each individual facility, but it also shone a light on the fact that the reporting nationally in the long-term care market was not as robust as it needed to be during this pandemic in order to be able to track it. Next slide. Some of that impacted the patient safety and the infection data that came out from 2013 to 2017. Long-term care was already at 82% of all facilities had gotten an infection control deficiency. That was pre-pandemic. So you can only imagine since the pandemic what that rate looks like. There are 3 million serious infections in long-term care each year within our patient population, and 380,000 of those will end up to be fatal. That's an alarming rate for an infection control system to kind of carry that burden. And those were all numbers that were pulled prior to the pandemic. The last numbers that were reported were there were 142,720 resident and staff that were reported to have died during the 2021 pandemic of COVID. Next slide, please. The survey data that came out from that there were some new conditions of participation that were going to be implemented for infection control. And I'm sure you're all aware of all of the detail that came out of that. Once the emergency is over, emergency use is over, the accountability for us to be able to follow those requirements is actually going to be even greater. It's almost like the government kind of gave us a little test strip there to say, okay, here's what we're going to require of you. We're going to go a little bit easier during this time, but now the accountability that all of those things that they ask us to do will now be important to be implemented, and they're going to expect those during these next 2 to 3 years in that survey process. In 2020, there were 11,800 tags just for F880 in 6,600 long-term care facilities. There were 7% more immediate jeopardy tags in 2020 than in the prior 2 years put together. But in 2021, interestingly, F885 took over the top tag for long-term care, and that was the designation for the reporting to NSHN. So again, you'll see very clearly if that's taken over the top tag, you also know then that the reporting is being looked at very closely to be one of the additional markers going forward as to how they're going to measure care within our facilities. Next slide, please. F8885, excuse me, I was a little tongue-tied there, is one of the new tags that was added in these new guidelines, and that was the one that was related to the data to the residents, the representative, and families, and making sure that everybody was notified and that all the data was presented. There was also a new F886, which was the tag that was related to the testing of not only the residents and staff that you will now be measured on, along with F887, which was the education around the immunization of COVID-19 and some of the infections that go along with that. And then the final one was the F888, which is the healthcare staff vaccination requirements that they implemented. So you can see that the federal government has placed a great emphasis on infection control, vaccinations, how we're looking at that, how we're measuring it, and what that's going to look like going forward. Next slide. With that being said, there were also positions and additional staff requirements that were implemented during this time to help say, here's the importance we're placing on this. And by us doing that, here's also the positions that we expect to see within our facilities. Interestingly, they put out these guidelines back with phase 3, even prior to the pandemic, but not too many people had implemented them in the way that the government had requested that to happen. So going forward, I think that, and we have seen from surveys that it's going to be looked at even more diligently than before. I know previously I had been over a multi-facility group in which I, was tracking and trending 11 to 12 facilities throughout the pandemic and trying to help manage their infection control processes and their infection preventionists in each of those buildings. And when they brought me on as a consultant for that, one of the interesting things when I went in to look, I was like, let me see who your infection preventionist is. And someone said, oh, well, social work handles that. Or, oh, the administrator takes care of that. Or they do all the reporting. No. They were very clear about who could do this. And it was a nurse who had been trained specifically in the field, someone with a degree in medical technology, microbiology, epidemiology. So I don't know about you guys, but I've been in healthcare for a long time and long-term care for a very long time. And I've never been in a facility that had a microbiologist or an epidemiologist on staff. So that being said, I think it would be important to look at the criteria and make sure that we're following that to the letter. Next slide. In managing infections within our buildings, there were 3 elements that were really important to be able to manage and control and track so that going forward, we could keep our hands around what was going on. It was very clear that in the past, infection control pretty much in most areas was just primarily a nursing issue. That's where most infection control F tags were written from a survey perspective, but that's no longer the case. There were 3 areas that were going to be strategically important for us to manage going forward. One was our clinical practice and processes needed to be extremely tight and extremely outlined and taught very diligently to the staff that we're managing. One of the other areas were we were restricted, I guess you would say, was human to human contact. Previously in long-term care, it was an open door policy. People came and went as they chose. Staff and visitors were free to come, go. And you all know that during the pandemic, there were periods of time where it was basically lockdown. Nobody came in, nobody exited, everybody was screened. Controlling and managing those types of contacts were important. But more importantly was the environment. And environment was controlled by those other two factors as well. Environmental controls of infection became even more so important during our recent years in tracking and trending these things. And I'll show you kind of what that looks like and how I went around managing that and what the systems we put in place in all of the facilities that I consult with look like. So next slide. Environmentally, there were basically three areas that you have to look at in order to make sure that that's being managed correctly. That's the patient services, all patient services, and where they're being in contact with the patient, whether it's their bedside table, their bed rails, their call light systems, their TV remotes, their telephones within their rooms. All environmental things came into play during the pandemic. The cleaning of the staff areas became even more important in order to be able for us to manage the staff impact and the staff infection rate. We had to look at the cleaning processes for the staff areas, as well as the common areas and how those are managed for our visitors and our residents to have safe places to look at and see each other and manage that without feeling that was going to be a problematic area as well. Next slide. Human to human contact, we had to take a look at that in lots of different areas, everywhere from the patient care, human to human contact, not only from the CNAs and the nurses to the patient, but also the staff to staff interaction. How did that look when they're in the break room? How were they breaking? What did it look like? The family and visitor contact area and how they were able to contact with each other. Because during this time, there was a study that was done and they realized that really only 40% of the workers within the long-term care area were actually using proper hand washing, which we all know that's the first line of defense, is washing and cleaning our hands appropriately. And with only 40% of the workers following that process, we definitely had some ongoing issues and problems. Next slide. The third area were our clinical practices and processes. And so once we identified in our areas that the human to human contact was a problem and we had some breaks in systems there, and we identified that there was staff and environmental issues, that we had breaks in processes there, it was really important that we get our clinical practices and processes and education right around that and implement new things related to hand washing, PPE, donning and doffing, making sure that our policies were all tight and that all of the staff from all levels of the long-term care were educated on those. And then we had to come up with a system where we could manage the data that we had implemented, not only from the education standpoint and the policy standpoint, but also you're basically trying to track something that's invisible. So how are we going to go about doing that? So for me, it was really important from our team to look at it and say, you know, what is it we're trying to measure? How are we going to stop it? How are we going to be able to control it going forward? Next slide. Some of the industry gaps that were identified during this same time were we really did not have the technology in long-term care at the time to manage and track what we needed to do. I don't know about you guys, but I've been here a long time, so I'm fixing to share how long that's been. I mean, I still was doing building egresses and tracking it and color coding my infections on a spreadsheet and doing those kinds of things. That was not efficient anymore. When we were dealing with the magnitude of what was happening during the pandemic, it was really important for us as an organization and for the organizations that I dealt with to find some technology that could help us, make it my friend, use the resources that I needed, because in order to be able to keep your hands around it and manage it important and have those reporting capabilities, it could no longer be managed if you were trying to manage it on a spreadsheet and manage it with those simple screening sheets. You know what I'm talking about. That was a nightmare. During this time, you would have mountains and mountains and mountains of paper that we were trying to manage some of these processes on. And so there had to be a better way. And I was one of the people that tried to just seek it out and find it. Next slide. The technology tracking and reporting gaps that we identified was there was really, not only from a building perspective, there was no uniform global database that managed infections, hence the birth of NSHN. Like it or love it or whatever, that was one of the global processes and databases that had to be developed in the midst of this pandemic. Like some of the other technologies that came about, you no longer had the capability of screening every person with a mercury thermometer at the door. We had to come up with other ways of managing technology through infrared thermometers and things that could make the job more efficient, because remember, we're playing with less staff because we've got higher turnover. A lot of the staff are homesick, and we're trying to just manage the best we can with what we have. We had very fragmented historical data to compare to even know where to go at this point. The processes and the plans to management just weren't there. And so part of that is the outcome of what has been developed both with individual agencies, group agencies, long-term care agencies, corporate entities have looked at it in a different way, which has been a huge step forward in the long-term care industry. One of the things I will say, though, that previously compliance in long-term care was much different than it was in some of the other ways. It was pretty much a subjective thing, or it was a paper compliance process. And you all know what I'm talking about. It's like, check off the box. Yes, we did that. That's no longer the case. Compliance is the prevention going forward. So we need to understand that and just embrace that as part of the change that's going to have to happen. Next slide. Models of care, training, and supply needs were also those global gaps that were identified in the long-term care market. Number one, we started out with a poorly funded healthcare division. I mean, our rates were not high. So therefore, when it came time for us to recruit and retain staff at this much higher rate that was being offered out there in the world, it was almost impossible to compete. So we couldn't grasp the staff that we needed to kind of look at developing the model of care that we knew we needed, but those resources just weren't available to us. And part of that was due to funding sources. There was no structured supply resource pool in a lot of entities. In long-term care, you had basically had one supplier where there are multiple large groups that supply most of the needs. But when everything goes on allocation and you haven't ordered it in the previous year, guess what? You weren't able to get it. And so it caused the long-term care industry to say, hey, I've got to broaden my pool of resources here, because if I can't get it here, I've got to be able to meet the supply and demand of what I need, whether it be PPE, gowns, gloves, masks. I know some of the agencies that I was consulting for, had to resort to paint suits and everything else that we could get our hands on in order to make it work. And we did. And the resiliency in long-term care was phenomenal throughout this. But it also identified that we definitely had an outdated care model. What we had done in the past obviously was not going to work for us in the future, which taught us a lot of things that we need to be looking at additional resources, additional technology, and additional supply options that could help us be more efficient in our current model of care. Next slide. When we were looking for myself as trying to manage and keep my head around 11 to 12 facilities at a time in any one given group, there were several things that I needed to know that were available to me so that I could stop and prevent some of the extensive damages that were happening in other markets. I needed something that would allow me to make decisions very quickly. I needed to be able to support buildings from a multi-facility management perspective. I needed to be able to wrap my head around and have access to data at multiple facilities in a virtual world. I needed to be able to go through that system with my buildings and say, here's what I need you to do. Let's implement this quickly so that we can get a drop on this and it not cause additional problems. And I also needed a proactive way to educate at all levels, because no longer was it just a nursing problem at a building for infection control. It was now a housekeeping problem. It was a laundry problem. It was a dietary problem. It was a social and activities problem. And everybody needed to be educated at all levels of the facility on infection control and what that looked like and what their portion of that meant to the safety and security of the residents and their staff and coworkers as well. Next slide. I talked to you before about compliance is the key, and that is the prevention, because that is what's going to give you some real-time data. When you operate in real-time data with dependable data, you can make informed, compliant decisions that not only decrease staff time, make it more efficient for them, it will increase your compliance, it will increase your passage of survey. It will lower your risk, not only from survey perspective, but from a legal perspective, because I know many organizations right now are facing the outcome and the fallout of additional legal areas that are coming out saying, oh, well, you let my mom catch COVID, or you let my mom do this, or mom, this happened during this time. So I just want to make sure that compliance is the key to prevention. And that is the way that we're going to increase the positive outcomes going forward. Compliance is also one of those things that is going to decrease your expense over time. If you are having less infections and you're managing it appropriately, you're going to be down on your cost of your PPE. Your supply costs are going to be down. As well as I do, when you have outbreaks in your facility, you can look at your budget over that month and it's going to be really up there. You can track and trend your budget based on whether or not you were in an outbreak during that period of time. So compliance is going to be the key to that prevention level. Next slide. When you're looking at what's going to be needed to minimize the negative outcome for me, I needed something that I could manage from a dashboard. I needed a comprehensive system. I needed a way to monitor those multi-facilities at one time. I needed to manage multiple departments at a time. I needed to be able to see and have a snapshot of what was going on at multiple buildings at multiple times. And they needed to be able to call me and walk through with us what was going on and us help them come up with the solutions to manage it very quickly. I needed it to be able to give me alerts if there were things that were going on that I needed to know quickly. I also needed it to make it work more efficiently for the building. I did not need to add anything to them that was going to make it harder for them. And on the infection side of things, for me, it was important that I be able to manage multiple vectors, because just because I had COVID in the building and it's also flu season, that didn't mean that MRSA and some of the other vectors that we dealt with, the VREs of the world and the C. diffs, that they went away. They didn't. They got the back burner for sure, but I still needed to be able to manage those in the same kind of way that I was managing the pandemic. I also wanted all of whatever system or pieces that I could plug together during this time to be able to give me some reporting capabilities to include in my QAPI process, so that when surveyors came in, I could very clearly show to them what I was doing and what the proactive things that we were doing to implement meant to the outcomes going forward. It's outcome based going forward, and I needed to be able to show that to the surveyors in order to decrease my risk and my F880s during this time. Next slide. Here's just a sample of one of the systems that I chose during this time. I used it because it was very user friendly to me. It was very user friendly to my nurses. This is basically the tiles related to the rooms. And you that have been in long-term care for any length of time know we used to manage based on color coding our building that way when there was infection. So this system actually did that electronically. But as you can see down at the bottom, I could manage multiple buildings, and all I had to do was click on that building and I could drill all the way down to room 101, hall 1, what the infection was, who had it, when it came into play, and the dashboard management could drill it down for me all the way to that level. And then if you can look at this dashboard, you don't have to say anything, but anybody that's done the color coding in the past will know what I'm fixing to say. There's one little thing on there that stands out. If everybody in there is red with COVID, what's happening to the little person in 112? And what are we doing differently for them? This is where I could go into the building and I could say, okay, guys, this person doesn't have COVID right now. Here are the additional steps that we need to be doing in order to bed manage, make sure that this person stays safe, that they're doing these kinds of things. And I could literally assist the infection preventionists in each of the buildings down to the room and where to move and manage and help them manage from a corporate level down to that level of intensity. So that was very, very important to me, to be able to help and support the buildings from a corporate level and be able to see and manage where my buildings were at all different times. Next slide. The other thing too on the efficient integrated platform is I had set for myself ATP countdowns, which is basically measuring the contamination rate of your items within your facility. I had set these up so that I had set my PAR levels based on CDC guidelines, and then the environment control team in each building would test different items within the facility. And if they flagged out over that, I could literally go into my buildings and say, you know what, all the bed rails on hall 200 are contaminated too high. We need to do a deep dive cleaning there. I also could do this as far as the nurses station. What did the med carts look like? Anything that I had the housekeeping or the infection preventionist to test during that time, I could actually track and trend what was going on down to the hall, down to the room, down to the actual item, if it was an IV pole or if it was something that was going on in that area. I could actually manage it for my buildings and help them identify that. I actually implemented these platforms in all of the buildings, and we would go over them on a weekly basis during our calls. We would set out a cleaning schedule from that to make sure that the environmental piece was taken care of. We already knew that we had revamped all the policies, processes, and procedures. And then that way, these also pull down into reports, and I could actually share that with the survey team. And they were very impressed by the progress that was being made in some of these areas. You can clearly see when you have a spike, you can drill it down to actually who the person was that was assigned to that unit, and know that if you needed to do some additional education with them at that time, then you could even go down to that level. I could not have managed without some kind of integrated system for the level that we were wanting to do during this time. Okay, next slide. From that, all of the data management and dashboard management, you've got to make technology your friend in order to be able to move forward and implement good plans. And for me, those reports needed to integrate well into my QAPI process. And so you can see here, just as a sample report, Hall 200, looking at the IV pump in 202 was really high. We needed some additional training around that. We needed some side rails to be done. So taking a look at those snapshots and being able to pull those into my meetings, even on a morning meeting basis, or looking at that on a daily basis until it got to be under control, was extremely helpful. And it made the rest of the staff all pull together to say, our goal is we're going to get this number below this for contamination, because we want to keep not only our residents safe, but we want to be safe. And if the contamination level is high for the resident, it's also high for us as a staff. Next slide. Looking at things from a proactive and a future planning process, it's kind of just going back to the nursing process. In looking at the pandemic when it came out, I had to analyze, what do I currently have, what's working, what's not, and if it's not, I had to be totally open to looking at new avenues to make it work. I then had to prioritize, is this something that's a top priority right now? Is it a safety issue? Is it something that's going to impact multiple people? How broad range is it? What's it going to look like? Analyzing and prioritizing those steps that we're going to take, because if not, it's going to be overwhelming. When we're looking at future planning, I can promise you this is not the last pandemic we will see. You will see another one in your lifetime. If you stay in healthcare, you're going to see another one. And it probably will not be as long, as far away as we would like for it to be. These things are multiplying at a rapid rate. I'm be very honest with you. When I entered long-term care many years ago, I never had MRSA. I never had VRE. I never had some of the things that we now deal with. And I thought that was really bad when those came about. I had no idea until COVID showed up on the scene what it could really look like. But once you analyze and prioritize what the things are with your team, then you can look at your implementation process. What things do we need to implement? Do we need to look at dashboard management? Do we need to look at a system that's going to help us evaluate outcomes and give us those reports that we need? If I've got an infection preventionist, if I've turned them over 4 or 5 times within the last year because the workload is too much, I obviously need to be looking at some systems and processes that will need to work again. So that being said, refining your processes, being open to those kinds of things that will be able to implement those changes and make that your infection control process be successful and decrease your risk along the way. I think I'm going to turn it back over to Karl right now, and he will kind of guide you through how you can ask the questions. And I will be glad to stick around until after the webinar for anybody that has anything that they would like any additional information on, or would like for me to share any additional information about. Thank you very much for your attention.
Awesome. Jeanne, that was fantastic. Thank you very much. I found myself smiling as I listened to many of the things you said, and I know you couldn't see that, but I imagine many of our audience members were doing the same thing and nodding their heads at many of the things you mentioned. So thank you for your authenticity and sharing your stories with us. We will, as Jeanne noted, begin now moving over to the Q&A portion of the webinar. So you can ask a question by clicking the Q&A icon on the right side panel of your screen. You can upvote a question that's already been asked by selecting the up arrow to the right of the question. If you've been watching in full screen, you'll need to exit full screen mode to access the Q&A. All right, so I'm going to start with it looks like we do have a few questions coming in here, so I will start with the first one. All right, Jeanne, what, if any, tools or systems did you test out before landing on the system that you opted to use?
Well, we implemented multiple things. We did infrared screening technology at the front door because we were hiring screeners at a astronomical rate, which wasn't working, and we weren't getting good tracking with making sure that those things were recorded correctly. So we implemented that as one of their technologies. We didn't land on just one thing. That was how I managed my dashboard, but there were other avenues of infection control that I had to manage in addition to just the tracking and the trending of the infections. The screening process, which is another thing that they're going to ask about when they come into your facility. How are you managing your screening of your visitors? How are you using your staff every day? For that as well, that also was efficient, technology based, electronic, and it would house those for us, so I could get rid of some of those additional books and novels of paper that were not accurate at all times. So there were multiple systems that we implemented, and this was just the one that managed the majority of the infections throughout the process.
Understandable. There's not necessarily just a single silver bullet in the infection prevention and control world.
Right. Absolutely. There are multiple tools out there.
Very good. Right. How's your QAPI team, or how are your QAPI teams using environmental testing data today?
So they're actually using that on a regular basis. It's not just, they do pull it monthly to see where they are and what they're looking at, but they also look at it weekly. And so when they look at it weekly, they can say, all right, what do I need to focus on this week? Where are our guidelines around that? Do I need to look at a different process? Is what we're doing not working? If we're scheduled to clean this particular area this many times and we're still getting high ATPs, what's the gap? Where are we? We're not waiting till the end of the month to just use that data, because if you do, you're missing the opportunity to make the proactive changes along the way. So it's used on a more regular basis than that. And they all have access to that dashboard to go in there and look at that.
That's great. Yeah, more real-time data usage.
Real-time data makes real-time decisions.
Right. Excellent. Let's see here. What impact has surface testing had on your cleaning and disinfecting policies?
We did have to make some changes in that. We had to make some changes in scheduling and how that worked. We had to do some the infection preventionists in a couple of the buildings. We had to make that kind of a I don't want to say overseer of that process, but they would go back and double check behind some things to make sure. We had to look at, anytime we found high ATP rates, we would go back in and look at those and say, what just happened? Was it tested correctly? Then the infection preventionist could step in and say, all right, what do we need to do differently? And if there was something that she didn't know, then that's when she would contact corporate and we could come up with a plan on how to do that. We had to change some schedules around cleaning and those kinds of things as well. So what used to be once a week became once a day. At this point, if it was something that was scheduled, we do beds once a week. No, we're probably going to do it more often than that, especially in the COVID wing. We're going to do that every shift. We're going to do that every hour if we have to. So regardless of what that was, we kind of made those changes during that time.
Yes. I think we heard that here at Direct Supply quite frequently, how often our customers were having to do their increased cleaning and disinfection protocols, specifically on a lot of those high touch products and surfaces.
Interesting, I'll say this, and it's not always high touch. One of the things, and I'll share this just as a side note, we kept having an outbreak and the ATPs were not high on the items that we were testing. So that led me to say, okay, we're not testing the right thing because that bug is getting in there somehow. So we started digging down and looking, and I mean, I looked at everything. And what we ended up finding out was the name badges for the CNAs that were going in and out of the COVID wing, the ATP levels on those name badges were so high that they were actually, we found that to be a factor. So at that point, I said, no name badges in the COVID unit.
Yeah.
And they took off their name badges in the COVID unit for that reason and implemented something different for identification purposes. And the infection, we watched it over the next week and it trended down. So, it was a high ATP level on those name badges, which would not have been something that would have normally been a high touch area, but it was actually a vector for or carrying it through to that process.
That's a great call out. I think we think about you hear all the stories about how your cell phone is one of the dirtiest things that around a person, and I suppose a name badge could very well be one of those vectors as well. So, that's a great call out. All right, we have another question here from an administrator at a CCRC. So, she says that her IP, the person that was her IP left, and it was a nurse, and they left suddenly. They're having trouble filling the position. None of their other clinical staff can commit to 20 hours per week for the IFC. And she says, I've completed the CDC NHAIP courses. Am I okay to be the IFC?
No, not the infection prevention is based on CDC guidelines, unless you're a nurse or those guidelines that were on the slide, medical technology, those are the guidelines that they have outlined. Can you fill in the gap and do the reporting for a time period? Yes, but you can't be, according to the guidelines, can't be designated as the infection preventionist. It has to be a clinical background for that.
Very good. Thank you. All right. See, there's another request here. Can you remind again those IP certifications required in skilled nursing? I know you mentioned some of can you just bring that back up to top of mind? I know you had it on one of your slides.
Yeah, let me pull the slide. Can you pull the slide back up? Or can you send them the slide deck?
We will actually, yes, we will send the slide deck to all attendees at the end here. So we'll have that provided. Yeah. Okay.
Right.
Good call.
So they'll all be on the slide deck that they're going to send you, and you can look at that. But you can actually go to the CDC website, and it will you can type in up at the top. You can say infection preventionist qualifications, and it'll pull that up for you.
Good call out. Thank you. All right. Let's see here. So, how did you handle change management and the new policies and procedures with staff?
So one of the things that we did was it was not. Those were one of the things that were non-negotiable. It was non-negotiable. So they had to, whether it was at their screening process in the morning when they were checking in, they would have like a short meeting if there was an additional change. And you all know they were changing within the hour. So what somebody got trained on 7 to 3, by the time 3 to 11 got there, it's changed again. And so it was very important for us to have real-time training based on whoever was responsible. And so the infection preventionist in each of the buildings was responsible for the education and training of the additional staff. In some buildings, we had people in those other management roles, so dietary manager, those kind of people, they would be trained as a group, and it was their responsibility to train their particular teams on what it was that was going to impact their particular areas. So we had to make some a variety of different ways to get it done, but it was non-negotiable. It was non-negotiable. It had to happen. And if it did not happen within a time frame, then they knew that was a problem, and we weren't going to let them work a shift without being trained or checked off or fit tested or any of those things. It was non-negotiable. It's non-negotiable for CDC. It's non-negotiable for safety of the resident and the staff. And it's non-negotiable for your survey tags and your F880 fines.
You got to be a little bit of a stickler sometimes with these things.
Sometimes you have to draw the line in the sand.
That's right. All right. Is there a system to put into resident rooms that can disinfect a room that tests positive for COVID, sort of a filter of some sort to get rid of the virus? I don't know if you came across any of that in your studies and research.
I did not. And some of the research says that There's all things out there that'll say, certain HEPA filters and all these kinds of things. There's really not been any concrete data related to that. That's the reason I think that the CDC is stuck with the same system that they use not only in because CDC does things other than just healthcare. They also monitor restaurants. They monitor infection rates in airports. They monitor, their overarching entity for infection and disease prevention globally. And so that's the reason we went with the system that they recognized across the board, because it was going to work in my dietary department, it was going to work in my housekeeping department, it was going to work in any department that I had, not just in the nursing role. So there's certain things you can't put in the kitchen that you can do in others, but you can still test in the kitchen. So that's the reason we went with that particular system.
No, that's very good. Thank you. Yeah, and I will talk a little bit about a couple of other systems here toward the end of our talk today too, that might be helpful for some of our listeners. How much do these technologies cost? As it's harder for small facilities to incorporate a new technology. We hear that regularly, right? A lot of mom and pop organizations that out there. It's hard to fit these types of newer things into their budget.
Let me say this. The cost, we did a ROI on the cost of the particular systems that we got. It was less than one patient getting COVID.
Wow.
Less than a third of what it was going to cost if I had one other patient get COVID, because you're talking about additional PPE, additional staff time, additional, all of those things that go into that. And, the resources to man a unit differently, all of those things you got to play into the whole portion of that. And literally, when you're talking that amount of money per month to make sure that the facility is clean and safe, and trust me, it's a fourth of one F885 per building. So,
wow.
That you got to do your ROI on it that way and look at it from a global, open-minded perspective, as opposed to, this is an extra penny. Well, what is it going to cost me if I don't do it going forward, and we have another outbreak of something that's could be even worse than COVID? God forbid that could ever happen. But a loss of life is, what's that worth?
Yeah. That's true. Yeah, it's a cost of avoidance in a lot of ways, and obviously beyond the financial aspect of things too. That's a good way to look at it. Was there a tracking surveillance system beyond spreadsheets that you used? I would guess the answer to that is yes.
Yes.
You can speak a little bit about that.
So we did reporting, we did reports, and we pull things from our EHR systems and use that going forward. But it was a conglomeration of different things. So it was important for me to not have to go to this system and pull this system, pull this, and put it all together. Honestly, during the pandemic, you didn't have time to do all that. I mean, and then you had to make sure that they all matched up all the way across the board. And so for me, it was really important to drill down to as few resources as possible to manage effectively, that would have a consistent message across them, that I only had to input it once. I don't want to have to input it 5 times in 5 different systems and make sure that I'm coding it correctly in all the different ones. So for us, it was one of those things that, we wanted a one and done kind of thing. And so, which was why we went the route that we did with a lot of these.
Consolidation. That's a major time saver right there for sure.
Absolutely. Efficiency was everything during pandemic.
Oh, yes, absolutely. Let's see. Okay. Someone's getting right to the heart of it, I guess here. What is the name of the system you use for tracking? And do you know if Point Click Care has something similar to it?
I do know that there is a tracking system in Point Click Care. It did not, I looked at it as well. And there were portions of that were similar, but for us, we went with the system with Backtrack because we wanted the housekeeping, we wanted dietary, we wanted the cleaning processes in there. We wanted the whole building to be incorporated into one system. And in point click care, it was basically just managing, coding in what the infection was and what the med was and what the room was, those kinds of things. It didn't give me the option of, where's the housekeeper in this process? Let me print off a report for them to know what their ATP rates are. It didn't manage and measure that in the same way that says, all right, this is what I need you to do to help bed manage and clean this area up, or same thing within the kitchen or anything like that. Was not incorporated in our point click care system.
Okay, that's a good call out. Yeah, that you get more. It sounds like what you ended up
The whole building. I wanted a holistic approach to it.
Yeah. Okay. No, that's great. Just a few more here. What kind of effort is required to start up a testing protocol like what you've discussed?
Basically, it was very simple. Once they trained on the dashboard and everything, which they trained me first, and then I trained the infection preventionist in the building. And then the group that I went with, implemented, and they went in and they trained the housekeepers on how to use the testing equipment, and they trained the infection preventionist. So I was the backup. I could do it and help train them as well. But honestly, the group that we went with, they went in, they trained everybody, they took care of it, they managed it, they were a point resource for them as well. So it really wasn't an overwhelming burden, which was another thing I was looking for, because for me, it was like, I don't have time in the midst of all this to go train and, 12, 15, 16 different people and keep it up and going. And so they were perfect with that.
That's awesome. Yeah, it's helpful to have a little bit of support in the initial rollout so that everybody's on the same page.
Use your resources. Don't forget to use your resources.
Absolutely. All right. How do you use environmental data to complement or contrast patient data, specifically during outbreaks?
So we did it specifically during COVID units, measuring the clean units as well to make sure that they're not becoming contaminated. We could manage it too based on bed management. So before we started making COVID units, we were trying to manage all of our COVID patients in certain areas, and cohorting, all of those kinds of things together were really important in managing that, complementing that. Not only did we do that, but say a patient broke out and they had an outbreak of not just COVID, MRSA. For us, one of the things we implemented was, all right, all 3 rooms that are in that same vicinity around there get a deep clean on this schedule, blah, blah, blah. And then those are checked behind, so that we certainly don't want those things to be anywhere else. If you see that you've got a hall that you're getting C. diff going crazy in, same principle. It's all about tracking and trending and measuring and being proactive about it. If you see that bug is spreading, that was the only way for me to be able to measure something I couldn't see. Mm-hmm. And so it was important to say, all right, if I see that C. diff or MRSA or whatever, if I've got 2 or 3 popping up on a hall, I got a problem. And so I need to be doing some deep dive cleaning in that hallway on a more regular basis in order to stop that going forward. In addition to the education of the staff that are taking care of those residents.
Yes, absolutely. Ongoing staff education is a key component as well. Now this is great, Jeanne. Thank you very much. And I think there might be a few more questions that have come in. We are at the end of our Q&A portion, but we will take some of those questions and handle those offline here for a few folks if we did not get to your question today. At this point, though, we are going to be moving on to the product portion of the webinar to discuss how Direct Supply can help your infection prevention program. And we do hope that you can stick around with us for a few minutes. All right. So with more than 1 million products in our offering, Direct Supply has the broadest selection in senior living. And this includes all the essentials that you need for your infection prevention and control program, from popular brands like Clorox, Lysol, Purell, Diversey, Kimberly-Clark, many, many more. Over the next few minutes, I'm going to speak about them, as well as some of the innovative infection control tools that Direct Supply offers that align very well with what Jeanne just spoke about. And I'll call out some of the more traditional cleaning and disinfection supplies and equipment we provide to address any shortcomings that you may identify in your cleaning and disinfection protocols as well. All right. So as Jeanne noted, over the last couple of years, we focused very heavily on droplet and airborne transmission. It was almost as if COVID was the only disease-causing agent out there in the world. But as Jeanne noted, and as all of you, I'm sure, are all too aware, things like C. diff and norovirus and MRSA, those did not go away. They are still very much prevalent in senior living facilities, and they are actually transmitted by surface-to-surface transmission. So that's where we can enter in ATP testing. You did hear Jeanne mention that a little bit as well. ATP is an energy-carrying molecule found in the cells of all living things, and ATP levels indicate how effectively an EVS team is cleaning, as well as the risk for disease spread. So the higher an ATP level, the higher the likelihood of pathogens, which could lead to the spread of infection. An ATP testing system, therefore, can help infection preventionists measure the effectiveness of a facility's infection prevention behaviors. And they can also help them to correct them, to reduce citations, and also reduce HAIs and the costs associated with them. ATP readers and test swabs, like the ones that you see on the screen right now, are available now for purchase through Direct Supply, and they can be used as standalone items. To maximize the benefit that you get from ATP testing, though, as Jeanne alluded to, keeping track of the data via a cloud-based software program is key, and that's where Backtrack comes in. In addition to the ATP reader and test swabs, Backtrack's annual contract gives the user access to their innovative software platform, along with in-person training at the outset and ongoing phone support for the life of the contract. After you've tested a sampling of your high-touch surfaces and equipment, you can download the collected data into Backtrack software, and the software will provide the user with an easy-to-read dashboard, like what you see on the screen, that shows the user how to the contamination levels by department, surface type, equipment category, and also allows them to provide and document the corrective actions given to the environmental staff so that you can improve upon those things. It also allows for a regional view, letting corporate and regional heads of infection prevention see how their facilities are performing, and that way they know where they might need to spend additional time. It's a simple and yet effective tool to save infection preventionists time while helping them comply with CMS guidelines, and it empowers infection preventionists to provide tactical data to their environmental staff to reduce contamination and the risk of infection spreads. Beyond Backtrack, there are many tools available through Direct Supply that will help provide an extra layer of protection in the fight against infections. One tool that many of you, I'm sure most of you, are probably very well aware of, it took the world by storm in the early days of the COVID-19 pandemic, and that's the electrostatic sprayer. Electrostatic sprayers can more evenly and thoroughly coat surfaces in significantly less time than with traditional disinfecting methods. So you very well may be using them today, and if you are, I encourage you to continue doing so, both for daily disinfecting of your high-touch surfaces as well as for your terminal cleans. Another tool that's helpful is UVC light towers, and they are great at inactivating virtually all pathogens that enter light, both in the air and on surfaces. They're available in either a manual or a robotic form for full room disinfection of, again, like I said, pretty much any pathogen that you can imagine. A key advantage of them is that they don't require the use of chemicals, which minimizes their ongoing expense after that initial capital investment. Be aware, however, though, that because UVC light can hurt eyes and skin, humans cannot be in the room while the light is operating. A newer and less widely known form of UVC light called far UV has some of the benefits of traditional UV or UVC without the main drawback. Like traditional UVC, far UV is fantastic at inactivating pathogens seen by the light, both in the air and on surfaces. And it's able to do that using just the light, no chemicals. But unlike traditional UVC, far UV cannot penetrate the outer tissue of human eyes and skin. And therefore, you can operate it in the background while humans are present. Fixed and mobile versions of far UV are available as well today. Now, to verify efficacy of all forms of UVC light, make use of dosimeter cards. That's the little card item that you see on the far right of your screen. It can help validate that the light of your UVC device is actually employing properly and working most optimally. At the end of the day, using some form of enhanced disinfection will not only make your communities cleaner and safer, but they'll also give peace of mind to your residents, to their families, to your staff, and to any guests that enter into your buildings. Last, but certainly not least, no infection prevention and control program is complete without housekeeping and janitorial supplies. For dirt and soil removal, simple things like microfiber mops, cloths, and dusters are great tools. Studies have proven them to be much more effective than traditional cloths and cotton mops and cloths at removing dirt and even bacteria from surfaces with just plain water. Adding chemicals, sanitizers, disinfectants to the equation enhances the cleaning effectiveness of microfiber by loosening stubborn soils, and permitted that you allow the proper contact time, you can also kill pathogens as well. So whether you prefer ready-to-use chemicals, concentrates that you mix yourself, or dilution control chemicals, Direct Supply has you covered. On top of that, we offer a variety of can liners, paper products, soaps and sanitizers, and all the dispensers that go with them. And we really can truly be a one-stop shop for all the supplies, equipment, and technology that you need to maintain an effective infection prevention and control program at your community. For more information and pricing on all these products and services, head to Direct Supply's website, store.directsupply.com. You'll be able to find helpful resources, check out product availability, and place orders. And as always, you can also contact your account manager with any questions. This concludes today's webinar. Thank you very much for joining us.